First of all, it's a great honor to be here and a part of it for discussion about viral hepatitis with all over the world. And I put here about the title, HBV and HCV infection immunology. But my talk is not only the basic research, but also about applicability of immune intervention for the elimination of these two very difficult to treat virus, because that's why I put the subtitles here is elimination hepatitis virus possible. Maybe everybody recognize that immune intervention is a key to eliminate these two viruses, but still we don't have when and how to do it. Okay. So let me start with viral hepatitis disease burden. As Margaret mentioned, these two viruses are very endemic in the world. This is a report issued by WHO Global Hepatitis Report at 2017. These are the numbers of people living with these two viruses in the world. And this is a change of SVR and the individual base of SVR in the top graph. That is significantly improved by the SVR in the individual level because of the improvement of DAA treatment. But when we consider about the population level SVR, that is in the bottom chart, that is really miserable, I would say, because people who attain the SVR in the whole population with living with HCV is not so satisfactory. And the two issues we need to tackle for the finalize about HCV elimination from the world. I think this is very important data reported by Mitchell Schiffman from the United States. This trend, the increase of HCV new infection in the United States has stratified by the age groups. When we look into this trend, we saw that significant increase from 2010 about the new infection in the States. And the important thing is the most significant increase was found at a younger age, 20 to 29 years old. This trend is influential on the epidemics and the HCV prevalence in the United States. These two graphs are the prevalence according to the age in the United States at 2007 and 2015. Between 8 years spanning, we found an emerging peak at the 20 to 40 years old in the right graph. That is, most of the young guys are infected by PVID population, I mean injection drug use. The next hurdles we need to tackle about HCV reinfection. This is a very important paper by 2016 by Simmons et al. And this is a data by meta-analysis by reinfection population after 5 years who attained once SVR by interferon-based therapy. These three groups, according to the risk of re-exposure by HCV, we found significant difference, especially in the PVID population or incarcerated population. The reinfection rate is more than 10%. And what things more worse, that is HIV co-infected population. The reinfection percentage is over 15%. So we need to know how to control this virus at the situation, the new infection or reinfection. So immunology analysis is very important issues to be studied. This is a brief summary of how immune response occurs after HCV infect to the hepatocytes. After HCV infect to hepatocytes, the first-line defense might be operated by innate immune cells, such as NK cells and acute T cells. And these two cell populations are highly producible about interferon gamma or antiviral TNF-alpha. If HCV escape from these attacks by innate immune cells, dendritic cells come into stage, and that is exchangeable from peripheral blood into the liver. And these dendritic cells taking up viral antigens were moved to lymphoid tissues where they stimulate naive T cells to differentiate in helper T cells on CDLs and CD8 T cells. And after CDLs coming back to the liver, where these are attacked and the virus infected hepatocytes, which causes liver inflammation. And if the liver inflammation occurs sufficiently and effectively, HCV eliminates eliminate afterwards. That is a primary SCV cure. But when we compared about the difference between the SCV-infected people and the healthy donors, we found these players are functionally impaired, and most of the cases in the SCV-infected patients. This is a part of our publication about the comparison between the immune cell players and SCV infection. But the tentative results we had right now, that all of these players are functionally impaired, but that impairment is not so severe like HIV infection, but modest. So pervasive, but not only fully immune compromised situations are obtained by SCV infection. So we need to know how to tackle this SCV strategy to dampen the immune response in SCV infected people. We've performed the focused analysis of dendritic cell because these cells are very important cells that links the innate and adaptive immune systems. These two the dendritic cells have subsets in the human settings, and three subsets are major part. And these dendritic cell subsets are differ in the expression profile of TLRs. And we focused about BDCA3 positive DCs. It doesn't work. Can you move it? This one? Oh, okay, thank you. And when we found that after the exposure by SCV of these disease subsets, BDCA3 DCs are expression of toll-like receptor 3 and high producers of interferon gamma. In contrast, PDCs produces huge amount of interferon alpha in response to SCV. So these two disease subsets share the preventive effect of this SCV infection at the first primary infection. The problem is how the immune cells are restored or not restored after SCV clearance by DAA therapy. There are several papers published already regarding about the players, CD8 T cells and KTs or the other cells that changes significant after DAA treatment. SCV clearance induced the restoration of CD8 T cells but in K cells, but we don't know about the DC, what happened after the SCV clearance. So in order to find out the information to getting out from the small number of DC populations, we try to collect information by single-cell RNA sequence technology. This is a representative data of Tisne plot regarding the different clusters of different gene profiles. We found that 5 different clusters from human PBMC and the dendritic subsets. And according to the heat map plot, the expression of different 10 sets of genes we found, and then clearly the 5 DC subsets were found according to this analysis. So in order to prove about the importance of DC subsets in the clearance of SCV, we tried to find out that changes in patients who were under treatment of DAAs. And all these pilot study, the patients were cleared SCV RNA after DA treatment, 12 weeks. And the basic data about MDC2, the BDCA3 DC at the baseline, the frequency and interferon lambda production in chronic infected patients was decreased and functionally impaired. And we found that from the geo-enrichment analysis that one of the important pathways activated after SCV RNA clearance in the patients, we found that some of the apoptotic pathways or cell cycle pathways are enhanced after SCV RNA clearance. And in parallel with that, we found that the BCRX cell, that is the most important genes for surviving the blood cell, immune cells. BCRX cell expression is enhanced after the clearance of SCV. And in do that, so we found also the frequency and also the function of interferon and the production of BDCA3 positive disease enhanced and restored the clearance of SCV RNA. So this is one of the data which support the contribution of immune cell recovery after after SCV clearance by DAAs. So next story, the HBV infection. The chronic HBV carriers were performed mostly and vertical on horizontal infection at the infancy. And to prevent that, we had a HBV vaccine. Now, if it fails that most of the HBV carriers going to E antigen plus to E antigen negative cases and inactive carrier state. But the remaining 10 to 20% of patients progress to chronic inflammation and finally resulting in the liver cirrhosis and liver cancer. So we want to stop this process of progressors of HBV carriers in order to prevent liver cancer development. So immune intervention, this is a conceptual a picture that when and how to intervene the chronic carrier of HBV infection to improve the final outcome of the chronic HBV carriers. Among them, therapeutic vaccine is one of the remedies for enhancing the HBV response because HBV vaccine is really well known that it's safe and very powerful to prevent new infection all over the world. And in order to find out the important cascade of immune response in functional care, we pick up the chronic acute hepatitis B cases and also chronic hepatitis B cases who attain HBs antigen seroconversion. These three cases we comprehensively analyze about immune cell response and functional humoral factor response in the course of HBs antigen seroconversion. We found that these chemokines, especially the CXCL13 and the L21, the cytokines, significantly showed a peak at the peak of HBV DNA and declined afterwards. And the same situation we found in chronic cases who underwent nucleotide analog PEG interferon sequestration therapy. This case also, in the due course of a PEG interferon treatment, CXCL13 and L21 showed the peaks at the point of this administration. And the important thing is HBs antigen quantity and IL-21 the quantity at the peak show the inverse correlation, indicating that this pathway is really important for attaining a functional cure. So in order to drag out the many information at the same time, we use the CytOff system. The CytOff is a fax system combined with mass cytometry, which uses elemental bound specific antibodies. So we can analyze more than 30 parameters at the same time at the single cell level. And when we apply the CytOff analysis in this acute hepatitis B cases, the representative case we show here, we found that from the CytOff analysis, and the shaded area, that is the point of HBs antigen seroconversion, we found that PDCs and TFH and follicular helper T cells, and also HBs antigen specific, and especially antibody producing B cells enhance at the point of HBs antigen seroconversion. So this pathway is really important for HBs antigen clearance. And HBV vaccine, in order to find out the applicability of HBV vaccine for the treatment of chronic hepatitis cases, we want to know what happened after HBV vaccination immunological point of view. We categorize, according to the anti-HBs response, we categorize three groups. That is very high titer of anti-HBs after the 3 shots, and high and low and non-response. Threshold is 10 mil/IU per ml. So the first time HBV vaccination and history and acquisition rate, we examined in more than 3,000 healthy medical doctors who were immunized for the first time. So let me remind you that in Japan, burst dose hepatitis B vaccination was just implemented in 2016. So these populations are non-immune to hepatitis B virus vaccine. According to the gender difference, a male inheritor of the acquisition of anti-HBs after the 3 shots, comparing the vaccine strain, we had a 3 strain of vaccination. The comparison that pre-S2 containing genotype C menu vaccination was better, a little bit better compared to the other ones. The first time vaccination response, I think that is influential to the antibody maintenance afterwards. So we compare, according to the anti-HBs titers, very high and low, and the 3 groups. When we trace back more than 10 years and the dynamics we found, and very high titer after first time vaccination, they can maintain for the preventable level of anti-HBs for more than 10 years. So initial HBV vaccination response is really important for the maintenance thereafter. When we paraphorize about the response of immune cells, what happened after the HBV vaccination, this is a cartoon of the response. After HBV vaccination, antigen were taken up by dendritic cell, maybe dermal dendritic cell or lymphoid tissues, which stimulate by naive T cells to differentiate in follicular helper T cells. That is really important cells supporting B cell lineage in the germinal center. And TFH, by producing R21, B cell lineage differentiate into anti-HBs producing APC. So this scheme should be operated after successful HBV vaccination. So we need to clarify that which cell populations are increased after first-time HBs after first-time HBV vaccination. This is a gating strategy of immune cells, conventional FACS analysis to find out follicular helper T cells and B cell lineage subsets. I'm going to show the data on this slide. This is a scheme for the HBV vaccination, the pre, and after 7 months after the 3 shots, we collected PBMCs and examined about the immune cell populations. This is the data about follicular helper T cells, the result. In responders, but not in non-responders, follicular helper T cells are increased, especially the TFH1 and TFH17 subsets are increased because these are highly efficacious for the supporting the B cell lineage. And the finding is very interesting is when we compare about the titers after anti-HBs titers after 3 vaccination, we examine about the factors impacting about the anti-HBs titers. We found that, surprisingly enough, that before vaccination, the condition, that is the serum level of these cytokines and chemokines, CX09, CX010, 6 interferon gamma levels are positively correlated with anti-HBs titers after the 3 shots. So this data means that some kind of genetic factors are influential about determining the environmental and cytokine environmental the conditions which influence about vaccine response. So this summary is the vaccine study done by Hiro. And we found that 3 types of immune response are really important for sufficient anti-HBs maintenance. In the first-time acquisition of anti-HBs, the follicular helper T cells and B cell lineage activation is important. According to the anti-HBs titers, the preconditioning of the cytokine milieu before the vaccination is really important. I said interferon gamma or CX09, that was kind of Th1 type immune environment is really important for the anti-HBs titer. Because of the time limitation, I didn't show about the result of anti-HBs maintenance, but we found that memory B cell and anti-producing cell response are especially important for the anti-HBs maintenance. So the summary here is HCV is now a curable disease by DAAs, and maybe you all know, but the increase of new infection and post-SVR reinfection is becoming a barrier to HCV elimination. HCV is really an immune moderating virus, but still we don't know how the HCV control the host immune response in a deep sense of the word. Functional HBV cure is a desirable target for the clinicians, especially for hepatologists. But immune interventions is really a tall order. And some of the data I showed here in the functional cure cases and the chemokine, the R21 is a hallmark of HBV clearance. Also, we need to know how to use anti-HBs response. That is we learned from HBV vaccination study. To find out the more important information, we need to use some kind of innovative technologies. I show here the side of our single-cell RNA sequence technology, really powerful for maximizing about the information from limited number of human samples. So these are the members of the current our center. I appreciate for this, and also the collaborators and help us to provide very important, precious human samples. So I will stop here.